Today's didactic, we thought we'd revisit the diseases causing dementia, things that you should be thinking about, and then red flags. And this really is designed to be a very high level, quick kind of skimming the surface on the big topic and pointing you to other resources that are available. So we're going to move through this very quickly. And it's not meant to be comprehensive, but just wanted to cover some of the very, very basic things that I know many of you know inside and out. My hope will be at the end of this, we will all be able to recognize sensory medical and psychiatric conditions that impact cognition, or have the potential to, or raise risk for cognitive impairment. To also talk about how we would objectively measure these in a busy primary or other care setting, and then talk about the most common causes of dementia, the things you're most likely to see in clinical practice. Very briefly, an update on kind of where we are here in the United States. Over 6 million Americans with Alzheimer's disease, another 2.5 million with MCI due to Alzheimer's disease, which leaves a significant number of folks for whom MCI is due to something else, hence the importance of an early and accurate diagnosis if those things are arrestable or treatable. And then for individuals over the age of 45, there are 15,000 with subjective cognitive impairment, which may be a prodrome of MCI and further impairment, may not always. We know that age remains the greatest risk factor, still about 11% general risk after the age of 65, escalating as we get older, such that by the time you're in your mid-80s, there may be close to a 40 or 45% chance of having Alzheimer's disease. We also know that fewer than half of our individuals with dementia have a diagnosis, and fewer than half of those individuals are told they have that diagnosis. This is true statewide, nationwide, that the vast majority of providers do not have standardized protocols for how to detect, diagnose, and treat dementia. So it's part of the work that we're doing here. We also know that these numbers obscure some very important differences, including women being disproportionately affected, both in terms of living with dementia, so 2/3 of all individuals living with dementia are women, and moreover, 2/3 of all caregivers are women. Certainly, there are likely multiple factors at play there, and you cannot underestimate the psychosocial ones, including educational opportunities, occupational and health behaviors, which may help turn off or on other risk factors. Similarly, for non-Caucasian populations, we know that for older African American and Black Americans, that's 2 to 1 compared to our Caucasian counterparts. Or Hispanic populations tend to be diagnosed at a later stage and more severe symptoms. And we really don't know fully about our American Indian Alaskan Native populations, but it's probably 2 to 1. Based on some excellent work our colleagues at Washington State University are doing, as well as Kaiser, and certainly to respecting that there are often more differences between populations in these groups than between populations or groups themselves. So really being careful not to overly broad categories. And all of the factors that are at play here, not just increases in health comorbidities, but the structural and systemic things that shape access to healthcare as well, and health literacy. Here in Washington, where we all are in practice, we still have about 120,000 cases with an anticipated increase of about 17% in the next few years. It remains the 3rd leading cause of death. And we have had a 16% increase here in Washington during the time of COVID compared to the 5 years prior. That is true nationwide as well. And then, of course, these numbers are staggering. Just the number of unpaid caregivers, how much that ends up costing in terms of time and other resources, as well as the healthcare costs that come with that. So huge, huge numbers here in terms of a workforce that doesn't always have the training or health to do such a thing. So back to the kind of the trajectory of cognition as we age, we certainly know that things do change in our 4th, 5th, 6th decade and beyond. Things like processing speed, complex attention, aspects of short-term memory. These changes do not reach the stage or the level where they impact function. And for a significant subset of individuals, 6.2 million number. There is a different process going on with a gradual accumulation of amyloid beta or tau or alpha-synuclein that leads to a different trajectory in cognitive functioning. And the important things to think about here are the prodromal phase, where someone will have the disease but be asymptomatic, or mildly symptomatic, or symptomatic to the point that it is now interfering with function. And of course, there are stages within dementia as well, in terms of early, mid, late, a couple of ways to think about that. But this idea that this trajectory is very different than what we see with normal aging, and for a high number of individuals, progressive, not always though. The very first things we should always be thinking about for someone with concerns around changes in cognition are assessing things that could be masquerading or contributing. First and foremost, sensory changes. So making sure that you are assessing hearing and vision. Strongly recommend having a pocket talker and over-the-counter readers available. It seems a little unfair to ask someone to remember a list of words if they can't hear you, or draw a clock if they can't see you. Good. Also, the common dementia labs or metabolic conditions that can yield some changes in cognition, medication side effects, and polypharmacy, with classes to pay attention to here, like anticholinergics, especially over-the-counter things like Benadryl, Unisom, Tylenol PM, narcotics, benzos, benzodiazepines, for sleep medications. A couple of great resources. One is the Beers criteria, which Trang, our own Trang Lee, talked about in her two wonderful didactics, longer talks around pharmacy and polypharmacy, which you can access there. Also being sure to always be thinking about delirium, particularly for acute changes, things like urinary tract infections, organ failure, electrolyte disturbance, delirium that may result as a function of medications. Undiagnosed and untreated sleep disorders, which, boy, it seems like these are increasingly prevalent. A couple of good tools that you can administer, or someone in your clinic could administer, would be Stop Bang, which is great for obstructive sleep apnea. The Epworth scale gets at some other things that may be indicators of REM behavior disorder or periodic limb movement disorder. Also making sure that we're always thinking about alcohol, other drugs. Sometimes having to get very specific around, what's a serving, how many drinks how many servings does a drink actually mean? And the audit is a good measure for that. Further thinking about psychiatric conditions like depression, anxiety, screening tools or measures, including PHQ-2 or 9, the GAD-7, which is a little specific to generalized anxiety. The geriatric or older adult specific tools of the geriatric depression scale or geriatric anxiety inventory. And then always, in the back of the mind, thinking about the less common medical conditions like hydrocephalus, seizure disorder, or maybe some of the rarer neurological things, but these certainly aren't as common. I included this just as a reference for you. We don't need to go through it in detail, but some of the distinguishing features between dementia, delirium, and depression. Dr. Parsi did a wonderful talk with some differences on the MoCA that you might see. I will point you to that too, particularly between dementia and depression. So if we move out of the territory of normal aging into mild cognitive impairment, I think the important constructs here are that these are individuals who have demonstrable and notable changes in memory or some other cognitive domain. Might be multiple, might be single domain. This is detectable on objective assessment, but otherwise they're doing pretty well. Function is intact. They are compensating fairly well. They're benefiting from maybe some compensatory things or some increased effort or attention. Also very important to know that somewhere between 6 to 15% of individuals with amnestic or multi-domain MCI convert to dementia per year, typically Alzheimer's disease. But at least 10%, if not more, which we'll talk about in a future didactic, revert back to normal aging. So again, the importance of that early detection and comprehensive workup to see if there is something that's treatable or reversible, or at least arrestable. And just talking earlier about what does it mean for someone who has MCI to not change very much across 6, 8, maybe 10 years. And then, of course, this chart on the right is the updated one from Ron Peterson and his group around types of MCI, what that might mean as early indicators of an underlying neurodegenerative or other cognitive disorder, and whether or not there are biomarkers that are present for that, which may help turn off or on treatment options designed to target those biomarkers. Further down the continuum would be dementia, which again, umbrella term, really just describing this acquired and very significant decline in at least one cognitive domain, not always memory, could be executive functioning, could be language, that you either can observe on objective measures, or there's enough history and your own clinical observations, so it can come a couple of different ways, and that this has reached the point at which there is interference with independent living and ability to complete instrumental activities of daily living, and that you have made sure that this is not due or otherwise explained by underlying comorbidities, delirium, psychosis, or substances. Again, a very, very kind of brief skimming the surface on the big four that you most often see with prevalence. So Alzheimer's disease tends to be the most common, followed by dementia with Lewy bodies in terms of neurodegenerative or vascular for non-neurodegenerative, but prevalence. And the earliest symptoms, the parts of the brain, the architecture that corresponds to this, how the course looks, gradual insidious onset with a fairly steady course versus something with fluctuations that might steer you more towards Lewy body dementia, and then some of the underlying factors or biomarkers not always easily assessed in a primary care setting. So I will direct you, if you are interested in learning more about those. Each of those is a talk within and of itself. So we have all of those archived on our website. So Dr. Gaster did a fantastic talk on MCI. We've got a really lovely large overview by Dr. Parsi, Dr. Eisenberg, BCI, Dr. Parsi with DLB, and then our own Dr. Demoda Riley with FTD and FTD spectrum disorders. So those are there. I don't think any talk could be complete without including the Jack curves, Clifford Jack's work, that really kind of highlights the fact that this is a long disease and a slow burning set of changes that occur well before symptoms are evident. So clinical symptoms are evident. And this really, maybe, especially Alzheimer's disease, could be thought of as a disease of midlife, with symptoms manifesting 10, 15, maybe 20 years later, and with a very long, potentially 30-year course. So once plaques and tangles are present, which are the hallmarks of Alzheimer's disease itself, an individual could be pre-symptomatic or asymptomatic for 10 years. They can now then spend another 10 years in the MCI phase, with another 5 or 10 maybe with frank dementia, of course moving through early, mid, late stages. But this really is something that tends not to change too much year to year, especially as individuals embark to manage other health conditions and live well, which is some of our work here. The other thing I would want to point out is that I think historically we've made some errors in trying to figure out, is it this or is it that, versus how much of that and how much of this are really contributing. And some more recent data from our colleagues at UCSF that comes from autopsy-confirmed clinical pathological correlation work that would say of late onset individuals, 100% of individuals had 3 pathologies. For Alzheimer's disease, the most common co-pathology was cerebral amyloid angiopathy, followed by Lewy body. And the most common form of mixed dementia, especially in late onset, is mixed Alzheimer's and vascular changes. In a specialized dementia clinic, historically that has been thought to be, well, maybe it's closer to a quarter, but we know in community samples it's closer to 60, 70%. The vast majority of individuals will have periventricular lesions, although how much before they contribute, where before they contribute, it's still up for grabs a little bit. If we think about the folks who need further workup or maybe a specialist referral, part of our thinking and our work with this is that individuals in primary care settings can and should be diagnosing dementia for a significant number of cases where it's clear that's what's going on and you have the tools, the training, and the resources to do so. But for some folks, beneficial to have a different set of eyes or maybe more advanced diagnostics. These would be people for whom their onset's in their 40s or 50s, anything before the age of 65, particularly absent of family history, that an atypical onset or course. So this is someone who would have a rapid onset without any clear datable events and a rapid progression. Unusual neurological symptoms, and then of course the neuropsychiatric symptoms, which are both difficult sometimes to attribute an etiology as well as to manage. So these would be hallucinations, fluctuations, and kind of psychiatric behavioral symptoms or psychological symptoms, and then neurological change. I wanted also to include some resources and references here for the things that we've talked about, including, if you're not familiar with Pocket Talker, there's the link for William Sound. The Hearing Loss Association of Washington is also a great resource. The most up-to-date MIRS criteria, the original article from the Stop Bang measure, which has that as an appendix. You can also find plenty of online versions of that. The Upward Scale, Audit, Depression, Anxiety measures. And I think with that, I will stop. And there's my contact information, which I already have, but in case there's anything else. And I will stop sharing for a couple of minutes here. And again, very, very skimming the surface on many of these things, but wanted to cover some of the basics.
And I'll just chime in. What a terrific way to start off the year. And thank you, Dr. Rhoads. And we have a couple, and Carrie seconds that. She echoes that. Thank you, Carrie. And I think we have time for a couple questions. If there are any pressing questions.
I would also open it up to thoughts. If there are other things that you use and that you have found beneficial, or if you've used some of the things that I listed and have found it really doesn't work, I'd be deeply curious about that too.
I'm always curious on how to address a patient who has perceived cognitive impairment, but then tests well and seems to be doing pretty well functionally. I don't want to be overly reassuring, but I feel like I can be very optimistic, and it sounds like there's not too much harm in being optimistic and reassuring, but that the progression from that prodromal stage could be like a decade. So really just say, you know, you have a concern and let's just keep checking in. But does anyone else have like a way that they like to manage that kind of anxiety, but maybe it doesn't, not significant cognitive impairment?
I have my own script for that, but I'm curious what other folks go to.
I think that's something I see fairly often in family practice, and I will, in those cases, focus on the social aspects and encourage exercise and say these are the things that you can potentially do something about. So the things that are in your control, then try and manage those.
Excellent. Other thoughts or other scripts that people have to validate what the person is experiencing without, you know, maybe reassuring them that, you know, everything's fine, or invalidating their experience? Brock, I see your hand up.
Yeah, I mean, I will sometimes kind of make the analogy to like arthritis. So some people have, you know, a bad knee, and it sort of progresses and they end up needing to get knee replacement. And some people just sort of live with a slightly bad knee for decades. And it's just important for us to kind of watch it and for them to exercise and stay active. And we'll just have to wait and see.
I think one of the other things that I have experienced frequently, especially with the really detailed objective hours worth of neuropsych testing that comes back pretty darn normal in the person thing, is I know I'm not, is to validate that fact that these tests aren't perfect. The MOCA is not perfect, and sometimes people notice these changes before the tools that we have are able to pick up on them. And fortunately, we now have an excellent baseline, and we're going to keep an eye on this while you're working on all these other things. But boy, good news in that it doesn't seem like anything crystal clear or scary at the moment. Other thoughts, questions, things that have been super helpful for you in your practice as you are maybe navigating the early stages of changes or tools that you use?
Chris, I would just add to that conversation that, it is a scary diagnosis, even mild cognitive impairment. And so making sure your patient knows that you'll do everything in your power to prevent it from progressing. And as Nancy has taught me, to really focus on the vascular risk factors. And so, managing, in addition to all the other things that I think we do really well in primary care, and providing that social support and encouraging nutrition and specific types of nutrition and healthy moving of people's bodies, increasing effort on blood pressure management, especially in mid-age, but if people can tolerate it as they get older.
All right, other questions, thoughts, before we move on to the case? Well, hearing none, we shall progress on. So it is my pleasure and with much gratitude to introduce Julie Holgado, who will be our first case presenter for 2022. And Julie's an ARNP at Cadillac Senior Clinic in beautiful Richland, Washington.
Thank you.
I will drive the slides, but let me know if you want me to go forward and backward.
Okay, well, we can proceed. Yes, I'm out of the Cadillac Senior Clinic. I do visit a rehabilitation center locally, and that's where I first met this case study, 73-year-old female. Educated, but mainly a homemaker. She did some prior daycare and domestic work, but I met her after a hospital stay. She had obvious memory loss, and this case is about her new diagnosis with dementia, diagnosed in July of 2021. This is a case study where I felt much more comfortable with really specifically labeling it as dementia Lewy body based on her symptoms, and it did reduce a lot of it did reduce a lot of my anxieties, and it did make me feel much more confident to have been having these echo dementia sessions to kind of rely on. She did have some comorbidities and past medical histories that I did want to make sure were not the cause of her symptoms. So she has a history of lupus, but without complication, no renal complication, an eating disorder, and she did have a vitamin B12 of 200 back in July of 2021, which we then reversed, and now it's a normal level. Hypothyroidism, which is stable, and she has this vague history of depression, anxiety, and fears starting around her 50s, which was not treated, and I don't believe was ever attempted to be treated. And then the story was that she started having cognitive decline, but living independently for the last 2 or 3 years. What precipitated her transition to the hospital and then the rehab facility was frequent falls at home, which interesting. Now that I see the dementia Lewy body, I do wonder if there was a gait problem to begin with. When I first saw her, at the rehabilitation center, I wasn't really able to evaluate that well because of her immobility from pain. So she discharged from the rehab facility to home with her family as the main caregivers, and then she has a hired caregiver daily. And her main concern on follow-up is that she has anxieties, and she has not been established with a neurologist. And the family says, what do we do? I've got this is the email from the daughter. She says, she's in a constant state of fearfulness and gets confused about things, like where her bedroom is, which increases her fear. She is terrified of being alone in a room, even if one of us is leaving the room briefly. And she has what I can only guess are panic attacks, although sometimes I wonder if there are many strokes. She suddenly has a terrified, stricken, far-off look. It's very intense, and she's not able to communicate. After a few minutes, she's returned and will have not a memory of what happened. Following these episodes, she is disoriented, off balance. So the daughter was, we were able to talk about, our goals for the patient in terms of like where we're at, that she's at home, she's ambulating with a walker and has no further fault. She's maintained her weight. She is doing very well at home. And we can advance this slide. Relevant family history, mother with Alzheimer's, father with alcohol abuse, and sisters with breast cancer. And there's a vague story of family history of maybe alcoholism in more extended family. So this is where her medications are at. And I'm seeing her for this appointment thinking, is her anxiety at an appropriate level controlled with medications? Does there need to be a medication adjustment? How do we determine, the distress that she's having with these symptoms, or is further explanation of dementia with Lewy body a good way to go? So medication-wise, I feel very proud that she's actually on a very few and I think appropriate medications for dementia of Lewy body, given that early on maybe it was not as apparent with the vitamin B12 deficiency, but she did have a D deficiency, the B12 deficiency. We did start Aricept, and Seroquel really helped with a lot of her symptoms in terms of decreased anxiety. She had been having hallucinations, and she really doesn't mention those any further. Levothyroxine is stable, and then she has Miralax as needed. So sleep, I also focused with the daughter about where we're doing well, because yes, no falls is a good thing, that her safety is pretty stable, and the home is a good thing. Also sleep is really improved, because when I first met her, she was very drowsy in the daytime frequently. And now she is reporting that she sleeps through the night, wakes up, and is pretty much awake during the daytime. Also wanted to, at first, she almost presented like there might have been some alcohol abuse, but on further history taking, it really was more of a social alcohol use and no current alcohol use. She still smokes. She does not use drugs or has no history of that. Family supportive, and the patient is very accepting of her in terms of capacity. The patient is very accepting of her son and daughter's care, and they both have healthcare power of attorney and financial power of attorney. So I think she's really a good case of dementia care done really well, because she is in her home. What we have not gone over much is advanced directives. So on her most recent appointment, we went over a packet, sent them home, did referral to our neuroscience center that has a liaison who can help them with the advanced directives too. And financially too, she's in a good place because she's got Medicaid, and so her caregiver is provided through her Medicaid benefits. On review of systems, there was a question if she's constipated. The patient denies. I question whether she is truly depressed, if it's more purely anxiety, because they say both, but I see what they're really saying is anxiety, and she has occasional incontinence. My physical exam is, we did perform a MOCA on my most recent exam, and the MOCA was surprisingly good. She just missed a few points on orientation and on executive function, the clock drawing test. Otherwise, she was intact. So it was 23 out of 30. Very good. But her slums prior to that in the rehab was very poor. So it is, again, in a different situation, in a more stable situation, she scored better. CT of the head was negative for vascular disease, and that was really reassuring to tell the daughter that while we might worry about other processes going on, I was able to kind of reassure that I don't think these are TIAs occurring with these changes in mentation, and it is somewhat a classic symptom of the dementia of Lewy body. We can move forward. Let's see if there's anything else. So physical goals, yeah. Physical goals, home safety, avoid falls. There is a care gap where her son goes to work at 5 a.m. and the caregiver comes at 8:30, which is good as the patient does tend to sleep in till about 8:30. So there's a pragmatic fear that the daughter has about that care gap, but in the whole scheme of things, they do feel the patient is happier at home. And they do have a goal, psychological goal, to reduce her anxiety and fears, which they are saying are worse in the afternoon. And then her emotional goals and social goals is she's going to be relocating to a new house with her son. And it's going to be more accessible. It is going to be a better house, but there's concern that that move was going to increase anxiety. And we might want to have a plan in place. So my questions are, how can we proactively improve this patient's transition to a new home? Such as, do we more aggressively treat anxiety? How do we kind of anticipate what might happen, or do we just react to what occurs? And what interventions? Oh, what I didn't mention is that another goal is to improve her son and patient's relationship when it comes to hygiene care, because there is some still discomfort when he has to provide hygiene care, especially for fecal incontinence. And I didn't know if anyone had a great way to make a son feel better about that, or maybe a link or a YouTube video, but that sounds like a really distressing situation to be in. And then if anyone would want to weigh in on how significantly her past medical history might have led to the eating disorder and anxiety that led to dementia, or whether the anxiety is a separate entity, or is that more of a prodromal of her dementia, because it started in the 50s. And I do wonder, is that separate, or is that the same process?
Excellent questions. And Julie, what an excellent case too. I mean, number one, you've highlighted some of the things that we just talked about in the didactic about assessing these things and making sure that you're ruling them out or treating them to get some clarity there. But also just, the comprehensive nature of the care that you're providing this individual with a tough diagnosis. I mean, Lewy body dementia is not an easy diagnosis to make. So great questions. I'm going to stop sharing. And, I definitely, I anticipate hearing from many of our hub team members. So Trang, I'd be curious to hear a little bit from you in a minute or two about the B12 piece and maybe some of the other medication pieces. Definitely interested in hearing from Karen around the care transitions piece. I know she's got lots of experience with that. Boy, the tough question about how to get an adult son comfortable with this type of care, if that's the way that has to be. Before we do that, though, I'm curious, questions that any of our community members have about this case, things you'd want to know that would help with maybe some recommendations, or just questions you have?
I know the thing that I haven't really pinned down yet is quite what her anxiety looks like, because when she comes into the clinic, she presents very put together, but she startles very easily. So I do see that. And from the daughter's email, it sounds like these anxious episodes are actually very internal as well. So, and it's not the normal agitation that I kind of expect sometimes of outward show or behaviors. It does sound like she is very internally. And so I don't know I was thinking of doing a geriatric distress checklist with a scale with the caregiver at some point. But even if I do that, I'm not even quite sure how to manage what our goals are with anxiety, knowing that I don't think I can remove her fear or her anxiety, if this is such an internal and such a part of her identity almost. So if anyone has any further questions, I feel like I probably could have presented a little clearer, so please do ask clarifying questions.
Julie, this is Kristen. Nice job on your case. Sounds like a complex situation, as many of these are. I had one question. You talked a little bit about her family history of alcoholism and some different things there. I'm curious, were you able to ascertain if she's ever experienced any abuse that came out during your discussions with her or anything like that?
That's a very good question, because I know that the patient is very guarded, so she has never talked about her past. And this conversation with the daughter was kind of alluding a bit to the daughter's father, the patient's husband at the time, had been alcoholic. And with her family history, I do wonder if that is a piece that I'm not quite sure even how to approach. But I imagine there is maybe, especially with her, startle response and her anxieties and fears, that might be a part of what's going on too.
Thanks.
Thanks.
I think maybe a parallel question to that was that the syphilis testing was absent, and if there had been sexual abuse or those types of things, is there a higher risk that could be discovered?
That's a very good question. And I do wonder if I should start doing the syphilis testing, like the RPR, more in my common just workup. I mean, I imagine, is it something that you commonly just add to your normal workup when you're looking at memory problems? Yeah.
I do routinely, although I've never found it ever. I guess when I was in residency in the psych ward at Harborview, I found one case.
One case is definitely significant. Yeah. So I think I will add that to her next lab work. Mm-hmm.
Oh, I see Brett has a question. Is home health involved? And could you get PTOT out to reassure her about the move to the new home?
Yeah, they have been involved recently. So she probably discharged from home health 2 or 3 months ago. So it might be reasonable to re-refer if she gets to the new home and is having trouble. That's where I question whether I get proactive and do referrals ahead of time, or if I wait to see how she does, especially as home health might want to see a justification. So I think that's a great idea to have like a low threshold to re-refer.
Julie, this is Kimmy. Thanks for the great case. You were mentioning that it was hard to obviously do a comprehensive motor exam when she was in so much pain in the hospital. Do you have a sense of the nature of the falls? Were they mechanical? What was the setting for the falls?
The story I received was that she was living at home and that she would just kind of fall over, like lose her balance. That is the story, is more of a mechanical lose balance. And the type of eating disorder I'm being told is that she was anorexic, and that she would just not, no purging, but she would just, would not like to eat to not gain weight, was fearful of eating. Now her current weight is fairly good, 105 pounds for a 5'3". So that means a BMI of 19. So she's looking like she's getting kind of a healthy weight now.
And Cynthia, it looked like you had a question too. Are you able to mute or unmute and ask that?
Hi, I just wondered what kind of activities she engages in now and what are her interest level? What keeps her occupied during the day? Does she watch a lot of TV? Is she listening to music, reading?
You know, that is interesting because she's really never talked to me about things that interest her. She's very reserved, very internal, and I do wonder what she does. And then having her be more active in positive ways might reduce time spent more anxious and fearful. Yeah.
Julie, this is Rhonda. This is totally anecdotal, but as you guys were talking about activities during the day, I recall that I've had a few patients previously who, whenever they had access to live television, particularly news, they had increased episodes of anxiety and paranoia, don't we all? But particularly in, these patients. And so I'm wondering if that's something, from an educational standpoint that might be helpful for the son. What are we kind of exposing to? What kind of atmosphere are we creating or something along those lines?
Absolutely. And then even on the other side of it, I remember Allison's talk was, there's like the TV stations where it's very calming stations you can watch, and maybe having something like that on when she moves to a new home could just give a different ambiance of calm too. Yeah, that's a good thing to assess.
Yeah, these are all fantastic questions. Others, or from our hub team, any things that you want to know before we move on to maybe some recommendations?
Yeah, I would like to ask about the two questions. First, related the anxiety and the history of maybe questionable sexual abuse, if it's changed in any way, even if you know it, the management or the treatment. And my other question is about, you mentioned that you started the Aricept and the Seroquel, and then you see kind of improvement. So the improvement was also in their anxiety, sleeping. What was the main, so how Seroquel, what was the purpose of prescribing her to address her kind of, so that's my two questions.
Yes, I'll just, the last one, the first, the improvement. When I saw her in the acute setting, she really had a lot of, she really was more agitated in that setting, in the sense that she had delusions and hallucinations and very, very anxious. So the Seroquel, let me pull up and see which one was started first. So the Seroquel, we started the Aricept in September. And so the Seroquel was started prior to the Aricept to reduce those really acute, agitated, delusional, hallucinating symptoms. Though she never had an infection. She had the vitamin B12 deficiency. She was in an acute setting. She had just had a fracture. She had just been on pain medication. So there was probably a component of delirium at the time. Though the Seroquel did seem to reduce anxiety as well. And then the Aricept was added, and I would just say that she's been very functional and she's doing well at home, was kind of a way that I gauged that was being successful too. And then the first question is, I would love to know, if I were to find a further history of trauma, I would really love to know if someone else has advice on how to address that in terms of her care. Yes, because I think she has memory enough to engage with a counselor, and it seems like maybe a psychiatric referral would be beneficial, and yet I would maybe a referral would be helpful, but I don't know if anyone else wanted to weigh in on that. Do you have any advice on maybe how to approach treatment of possible trauma?
My first thought there would be, this is Chris, you'd want to do a very a careful interview, right, to get a sense of what that could be without leading her down a path of a response that you're looking for, just in terms of getting a good sense of her history and maybe corroborate that with her family. But my first thought was that there's some decent evidence that people with early stage dementia, historically it was thought that cognitive behavioral interventions, psychotherapy, not helpful. There's some lovely data that would say it actually is to a certain point of cognitive impairment. I do not know whether or not any of the evidence-based treatments for PTSD or trauma-based therapies have been evaluated with cognitive impairment at the stage of dementia. That would be something interesting to look at, to see if there is something out there, who does that, and how would you get her connected. The other question would be, are there medication treatments? And Brett asks an excellent question here in the chat. Has she tried other antidepressants, sertraline, citalopram?
That's a great question, because she has not tried she's not tried other antidepressants. So I am curious about an SSRI for her. I would be curious if someone wanted to weigh in on that, because I think my hesitancy is the worry of a poor reaction in the Lewy body dementia, but it does appear that SSRIs are safe and can be used.
So Dr. Eisenberg and Dr. Demotta-Riley both nodding during that. I don't know if one of you would like, or anyone else would like to unmute and weigh in.
I can weigh in. I mean, I think that it's a good question, and you would consider, starting low and going slow. And I'm glad that she's doing better, certainly. And before I added it, I would draw down maybe on the quetiapine judiciously and with a lot of careful oversight, because while it is of the atypical antipsychotics, maybe a safer choice if she's doing pretty well. And I wouldn't change anything probably until she's maybe transitioned. But so she's able to walk well with her walker now, and she's not falling, and she doesn't look too Parkinsonian. Is that?
No, that's correct.
Okay, great. So maybe you could consider, and I would be very curious to hear from Trang as well. You consider cutting back on the quetiapine during the day.
Yeah, I like your suggestion of waiting till after, because I was wondering about an antidepressant and wasn't sure if it would be beneficial to get it on board ahead of time, but then you don't want to upset the apple cart if you were to add in another new element before she starts transition to a new home too. Yeah.
It sounds like right now she's doing, as you said, pretty well. And I agree with you. Sometimes, if it ain't broke, as we see, right?
Yeah.
I think those are good instincts.
How soon, Julie, great case. Do you know how soon she's going to be moving to the new home?
Yes, on the 31st of this month.
Oh, 31st of this month. So about 2 weeks out or so. Perhaps we can kind of keep, if she's doing well, keep it the same after the move. But I agree with Nancy and Barack about decreasing Seroquel, because people with Lewy body dementia is more sensitive to antipsychotics, and it might help her because she previously had delirium. So I think now if she's doing better, then we can consider looking at kind of lowering the dose. And then it sounds like she still has anxiety. I think SSRI is good for that, either citalopram or citalopram with low dose. Another question that you have was the vitamin B12. If vitamin B12 has any association with the cognitive impairment. So this is what I found in UpToDate. And it says that vitamin B12, B6, and folate, while there is evidence that low serum levels of folate, vitamin B12, B6 may be associated with impaired cognition and risk of dementia. There is no convincing evidence from clinical trials of vitamin supplementation prevents dementia. This was illustrated by a meta-analysis of 11 randomized trials, including 22,000 participants over the mean duration between 2.3 years to 5 years. So they have like different clinical trials. The vitamin B treatment group compared to the placebo group had no impact on cognitive domain score from the baseline to the end of treatment. So therefore, there is no evidence that even though there's an association, but after we supplement vitamin B12, we don't see there is an improvement in cognition. However, her vitamin B12 level was really low, so supplementing is good to prevent other complications like anemia, pernicious anemia. But in terms of preventing dementia, there is no correlation. There is no improvement in terms of cognition after supplementing vitamin B12.
That's disappointing. So I wonder if I think some resources I've read that it's like a risk factor, but didn't know how strong of a risk factor it was, or if it's, well, it's disappointing that it doesn't improve by improving the deficiency.
It's part of the dementia workup. It's to do the blood work to see a patient is vitamin B12 deficient. And if the patient is low, it's important to do supplement. But in terms of supplementing B12, will it reverse dementia or cognitive impairment? I mean, there's meta-analysis that it
Trey, I wonder in that study, were those patients who were low on vitamin B12, or was that all comers of people with memory loss? Because if there's someone who has dementia that's caused by their B12 deficiency, then treating the B12, I would assume, would improve their cognitive function.
We would expect so, but they did there were 11 trials that they looked at, and with 22,000 participants, and they actually gave patient vitamin B12, compare that to placebo. They follow patients from 2 years to 5 years, and they looked at the MMSE score. They found that there's no improvement compared to placebo. I can dig into that. I mean, this is something I read prior to the meeting, but I did not dive into like really, inclusion criteria, all of that. But that's what I found. I don't know how, Barak, do you have vitamin B12 deficiency patients when you supplement patients with B12? Did you find any improvement?
Yeah, I mean, it's definitely not the kind of thing that you're like, aha, hooray, I can fix this now. But it is so safe and so inexpensive, and there is some association that it's a good thing to find and a good thing to treat, but it's not with like a tremendous amount of feeling like you have hit upon a solution to somebody's problem.
Well, I think that's a really good clinical pearl to know, because I think without, knowing that study, I was kind of under the impression that it was a little more significant, like, oh, maybe we can help, by treating this, but you prevent further deterioration by treating it. But I did feel I'm disappointed because my logic was that it would help. There was a note in the comment about prazosin in use of trauma and in use of PTSD. I'm wondering, I'd probably be apprehensive with her history of falls and the potential for orthostatic, though I don't think she's had orthostatic changes. But I imagine that would be an option if if needed for the anxiety too after an SSRI. Sarah, would you tell us more about the prazosin and use of dementia? Oh, audio not working. Started at lower doses in dementia. I will definitely take a look at studies that way, because I don't think I have thought of using it in that case.
The PEACE AD study is still ongoing, and there was one done in nursing home settings, community nursing home settings, which is, I don't know if the data is published for that yet, but we can, if it is, we'd be happy to send it out as a resource. I'm curious too, any other recommendations regarding care transitions, which are often challenging and fraught with some exacerbations of cognitive symptoms. Karen, I don't know if you're able to.
Sure.
Oh, good.
Yeah, I'd be happy to dive in about that. So a couple of things. I do appreciate Cynthia's comment around sort of like what are the routines that she's already doing, and maybe trying to find out a little bit more about those, and then doing a lot of encouragement with the family to see if they can help them maintain those routines throughout the transition. Also, I think about Franja's comment about kind of avoiding distressing news, and that also makes me think about Zinnia TV, which is that great video series created by Allison Schreier as a way to kind of put on some background calming and beautiful images. If she'd be interested in that, that's just such a great resource. I think that she is I think that the family's great to be thinking that there's going to be an adjustment period, because I think that's one of the things to recognize, that there often is an adjustment period when you have when you have any big change, especially a change to a new thing. And so just being aware of it and recognizing that it's often temporary and that there's things that they can do, and just sort of like expect there's going to be a little bit more confusion or a little bit more symptoms until she sort of gets used to those routines. And then you can make that easier by sort of doing those routines that she's already doing, sort of figuring out which ones are kind of, contributing to her having like a sense of purpose, things that she likes to do. Another important thing for them to try to do would be to try to maintain like a space of calm or safety, both at her current place for as long as possible, and to have set up at her new place when they're ready to move, so that even if the house, will inevitably be full of chaos and disarray, to have at least like one house, one room that's kind of hers, that maybe would have some familiar things, maybe, blankets that she finds comforting, or photos of the family, things that are, reassuring to her, and letting the family know that those sort of reassurances, both before and after, that, she's safe, and that, we know that this is a hard time, kind of validating that fears, like it's, like they say that moving is one of the top 5 stressful things that's stressful for all of us. We're going to get through this together. Let's be patient with each other, and just reminding people to sort of say those things out loud, and to everybody taking care of themselves. I also know that there are some really good resources on the Lewy Body Dementia Association website. They're pretty tricky to find. So you find them under I think it's under, I'm just going to look at that really quick. I think it's under resources, where it says, actually under caregiving publications is where I feel like the good stuff is. And in there, they have a couple of different care briefs. They've got like 6 different care briefs. And one of them is strategies that may prevent behavioral changes, non-medical ways to respond to behavioral changes. I feel like that's just some good basic facts for all of us. And it works for most dementias too. And it's just a very nice practical thing that you can hand out to folks, with those reminders about routines, maintaining calm environment, thinking about, problem solving, that problem solving techniques for when there seems to be some triggers. those are just some really good publications that are available through there. And I can send some links to those. Yeah. I don't know if other people wanted to chime in about the helping with adjustment. I know you had also asked about the continence issue too, so we can circle back to that too if somebody wants to do any more talking about the adjustment to the new home.
Yeah, because I feel that because I was talking to the daughter, and I've talked with the patient, with the son in the past, and he's also very stoic, so he's not really complained to me about it. But I do feel like that dynamic would be something to really improve on for her to stay in the home, because he is her main caregiver. If he's uncomfortable, then if her dementia advances, thankfully she does have the Medicaid benefit where she would be able to get placement, but it would just be, how do you say, it would be regretful if it was just a matter of him needing to feel more comfortable, if it was something that he, with more education or time, so I think having like little by little, just giving more of these resources. I gave the LBDA, the Lewy Body Dementia Association website link to the daughter, so I hope she shares it with her brother, but then also maybe, like you said, just directing to the actual articles, because it is a very large website. Yeah. Do you have some tips on the incontinence?
Well, I guess I have some questions about it, so I sort of wonder about like, when is the incontinence happening? Are there some things that, can be done around, do they have some good, hygiene habits? Like, is she trying to, use the restroom at a time? Is her bathroom set up in a way that's relaxing? Are there, things sort of related to helping her be more comfortable that would reduce the risk of accidents? And then hopefully just, if she's getting distressed, I'm guessing that would be more distressing for him as well too. I do wonder about like, if it's worth it to kind of dig in a little bit more about what it is that's uncomfortable. Like, is it because it's his mom, or is it really that he just feels like he doesn't know how to do it and he'd be more comfortable if he had some training? So getting a little bit more cues from him about what it is that makes him uncomfortable. I wonder if, the caregiver that's already coming into the house, if that caregiver is providing some care, could she also do some teaching for him? Like maybe he needs some techniques about that.
That's great suggestion. And I like the suggestion of kind of like the hygiene routine as well, because what I'm hearing is, especially the fecal incontinence, sounds like that it might be that she doesn't anticipate her bowels and then become urgent. And so if there was more of a routine of hygiene, of routine of toileting, then it might not be so much of an urgent bowel movement becomes incontinent.
Yeah. Also on places like the Alzheimer's Association, they've got some good materials on there on sort of related to like helping somebody go to the bathroom when they're at, moderate and more advanced stages, and sort of how to make the room, more relaxing. Little tips like, try to, I was just looking at it now. It's like put using like one of those sponges for, soap, or, buying one with like a little pocket in it to sort of keep the soap in it. Just there's some very practical, like, these are ways as a care partner that you can make the bathing experience more pleasant for your loved one and for and hopefully for yourself too.
Great.
Outstanding.
Yeah,
As always,
I'll send those links too.
Well, and we will send them out to everyone. Those sound like fantastic resources for us all to have. So as always, you are a wealth of pragmatic tools and skills. So Julie, hopefully we answered, at least partially answered all three of your questions. It looks like we might have. I'm mindful of the time, and we'll certainly summarize all that and send it back to you. Although I noticed you taking notes, which is a wonderful cognitive compensatory strategy.
Yes.
I will also advertise that Our next session on Friday, January 28th will be our own Dr. Nancy Eisenberg talking about dementia prevention, modifiable risk reduction. I thank you so much for not just attending, but such great questions and participation and just being part of this community. It's really, really wonderful. So take good care of yourselves, each other, and we'll see you in a couple of weeks. All right.
Great job juggling both the didactic and facilitating.
Thanks. I was like halfway through, I was panicked, like, oh my gosh, am I supposed to be keeping notes about the case here too, which I
No.
was kind of fumbling with this. Thank you for doing it. But, yeah, what a great case. What a great case. I was thinking about you, Barack, in terms of the, you know, one of your criteria for the specialty referral involves Lewy body, given how challenging it is sometimes. But
yeah, I mean, to me, that the diagnosis was super fuzzy there. You know, I think that the fact that she did so well on the MOCA and that so many of her symptoms are sort of neuropsychiatric, but not sort of like screaming out as like visual hallucination, Lewy body sort of hallucinations. You know, I mean, this is like a totally fascinating case where, you know, like 5 years from now, she could be like exactly the same as she is now, right? I mean, this is not like screaming out to me like a progressive neurodegenerative disorder necessarily. And you know, and I also am just like aware of just like how hard it is to find good geriatric psychiatrists out in beyond the Puget Sound area, you know, so I hesitate to sort of like strongly recommend that, because it could also very well be that she would end up finding a geriatric psychiatrist who sort of kind of throws the kitchen sink at the person, and then they end up on like, you know, 8 different psychiatric medications all at once that aren't necessarily helping. You know, it's a super challenging situation.
Well, I guess that also raises the question of, you know, you've got somebody who is, you know, clearly benefiting from this program, and, you know, her confidence is increased to make the diagnosis of Lewy body. You know, how do we handle it when it's like, well, hang on, maybe not, right? I mean, you don't want to, you know, totally discourage her or undermine that, you know, expertise she's gaining, but like, how do we do that?
I know people are far more likely to die in an avalanche after they've had an avalanche course. Just
that feels so relevant for so many things.
And she bounced back pretty quick, though. You know, she did. To your point, Barack, functionally. So we're gonna. I think in the recommendations, you know, since she hasn't seen it, I think her instinct to refer to a neurologist is really right based on presentation, and
there is one pending. I mean, so this would be like great. It would be great sort of like follow up to get of, you know, what, I mean, because it's like so hard for us to try to sort of diagnose this sort of in a case study like this, that, you know, getting some sort of 3 and 6 and 12 month follow-up of what is the diagnosis sort of like shaking out to be, and what kinds of therapeutic trials are undertaken.
Yeah, plenty to talk about with the, you know, transition and the consult, and, you know, maybe trying a few other things. Yeah, I was wrestling with how much, when Kimmy, when you asked about the falls, I was thinking you were thinking PSP and wondering how much, do you want to open that as a like, ooh, we talk about that as something to be keeping in mind, but it's so rare, would that derail the whole, kind of more pragmatic recommendations for her. But I don't know, I think it's probably good every once in a while to question those things.
Would
Yeah,
this
it was,
ever?
I think, oh, sorry, thinking about, to hear a little bit more of Parkinsonism type things, did that prompt anymore? Yeah, and I don't know if a potential future topic could be, let's say you follow somebody for a few years. When do you either revisit a question of a diagnosis, or I mean, sometimes we get that like a new family member appears, right, and sort of wants to challenge, like, I don't know. There could be a way that sort of a higher level topic that I'm sure plenty of us have had experience with, or oops, or this is all the data we could collect at this point in time. Maybe certain parts of a workup weren't able to be obtained, and so you're kind of left like, we just have to see what happens.
And it's not necessarily like, it was just hard to tell like how much of her psychiatric symptoms are new versus how many of them have been there for 30 years and not necessarily well diagnosed before that, and that some of her kind of functional ADL things, are like not that. I mean, like I have plenty of 73-year-olds who have, recovered from terrible falls, who are still sort of struggling with ADLs that are like unrelated to cognitive impairment. So there's just like there's just like so many like layers to unpack here that make the diagnosis really hard.
Another point, and I didn't want to go there, but I think we can come at it in a different way in a later echo, was around her description of these spells.
Mm-hmm.
And, certainly you have these fluctuations and you can have synchrony, and we all are familiar with how Lewy body dementia can present, but those spells, which were very brief, and then she was confused thereafter, have a broader diagnosis, differential diagnosis, certainly. So I think we can kind of come back to that in later echoes, right?
Yeah, it'd be interesting to do like a combined, or maybe have one of our epileptologists do a talk around the co-occurrence of epilepsy, or with dementia, maybe in like our second half of the year, deeper dive kind of things. I also like the one of like, what to do when you get it wrong, right? How to walk back a diagnosis, or when you miss something. I think that's an important skill to have.
Or even how to say, like, I don't have, this is what I think is going on, like, especially with MCI. I worry this may be due to Alzheimer's, but I don't know for sure. It's, how far do you go? And each person's a little different.
I like the way you answer, Barack. It's not a big bang, like you don't hit the big jackpot. I like the way you answer that.
I would just like to add that I was really pleased to hear that both the son and daughter are DPOAs, that designation has been made. So good for Julie around that, or whoever made that happen.
I just want to make sure I capture in my notes the future didactics that we see potentially sparked by today's conversation. How to walk back a diagnosis, but there was one about epilepsy.
Yeah. Dementia. Co-occurrence or subclinical seizures in Alzheimer's disease. We could maybe see if we could even invite, was Vossler here? And then now was he initially a while back? Oh no, at UCSF, and now.
Oh yeah, he's like now, oh my gosh, then he went to Minnesota. No, now he's at
Oh, no.
UCLA.
Oh, okay. Okay. Or we could share his papers. Or, yeah.
Yeah, or would we do a more like, like later complications that you can see in dementia?
That's probably more valuable for this group. I agree. Unless we have an early onset kind of didactic, in which case maybe we could bring that up as well. But I think you're right. From a primary, and Brock, you're nodding. So from a primary care perspective, probably we should have, right, as you know, in moderate to advanced, the risk is 1 in 4 or whatever. Yeah, like I think you're right. That's better. Epilepsy,
Yeah, like, right, like helping
dementia.
triage, like, okay, we'll just go along versus this is something that should be intervened upon. Sort of that red flag of moderate to severe stage. Yeah.
I like that.
So one question is, if like Julie has a question, if the son is comfortable taking care of mom because of fecal incontinence, what, Karen, have you seen sons willing to do that?
I mean, certainly both ways. When I worked in hospice, you know, some family members feel like no problem, it's their duty, it's their obligation, it's a privilege, and then others are like, well, that's crossing a line that shouldn't be crossed between mothers and their sons. I feel like it's really varies culturally and individually, and you know, I also wonder, like, given how anxious she is, I feel like that probably makes it more complicated.
Mm-hmm.
I was digging around on the Community Living Connections website to see if there was something in that county that might help with, you know, in-home, or you know, is that something you could take off the son's, you know, or the family's caregiving kind of plate? But I couldn't find anything as we were talking. I was going to ask Lynn if she knew of anything. But.
Yeah, well, you know, it's great that she's already got a COPES caregiver in place, and so, you know, ideally she could do some of the more personal caregiving. That's why I was thinking too, like having a routine where if she's using, you know, she's got a regular caregiver, you know, going to the bathroom during the day, and then it would just be more for, you know, accidents that are happening or less common things that they'd have to deal with that might be less, you know, distressing or overwhelming for the son.
Mm.
And I also don't know, like, you know, how often was there a daughter-in-law involved as well? I know there's a daughter, but, you know, could there be somebody else there that would just be willing to kind of step up and do that? So we didn't really dive into that as much as we could have.
You know, I know a bunch of people who have made it, like, gotten a little further down the caregiving path by installing a bidet.
Yeah.
In the toilet.
Right.
Just to, yeah, it kind of can buy you some time.
Yeah, that's right. Yeah, it's so interesting too. I feel like sometimes, like, people say, like, I could never do it, you know, just like I would never want to live under these circumstances, and then you get there and, like, you just do it. Yeah. You know, so sometimes people are able to just adjust given the necessity of the situation.
Yeah.
The bidet comment's interesting. Kimmy, our corticobasal patient that we talked about this morning, I saw that in your note as a recommendation. The bidet has been given as apraxia, and I thought that was a brilliant, like, yeah.
Well, the problem there is that it's great if you can use a remote, and yeah, he's to the point where TV remote, bidet remote. But no, yeah, I have had other people have a great success with a bidet.
Mm-hmm.
I wonder if you can get your Alexa.
Attachment.
Can you get your Alexa connected to the remote?
Yeah. Alexa,
to control the bidet.
Want to do some serious waterproofing in your bathroom?
Yeah, I know. That's yes. Now we need to completely renovate the bathroom for all kinds of things, and yeah.
All right. Well, thank you all for continuing this awesome project.
Mm-hmm. Happy New Year, everyone.
Yeah.
We're off to
Happy New Year.
a crazy start.
Yeah.
Happy New Year. Stay safe and stay healthy, everyone.
Yes, be careful
trying.
out there.
Trying it out there.
Mimi, I sent you the background.
I did, I got it. Thank you.
Okay, cool. All right. All right. Bye, everybody.
See ya.
You bye-bye. Have a great weekend.